Uh, Good morning, everyone, and welcome to this instruction course of Phaco in challenging situations, simplifying the complex. So we have a panel of speakers here, including a guest talk by Dr. Chang. Uh, and we have with us Dr. Kumar Doctor, whom you all know is an excellent surgeon, I would say par excellence. Dr. Ramamurthy, Dr. Tityal, Shreyas Ramamurthy, Gaurav Luthra, and Raghav Malik. So we'll be discussing various situations which according to us are complex. And as all of us are doing phacoemulsification or femtolaser assisted cataract surgery, how do we deal with these situations? So without much ado, I'll start with the first talk, and that will be on the femtolaser assisted cataract surgery in complex cases. Hi Gaurav, morning. Come. Well, can I have my slides? Yeah. Okay, so I'll be talking about femtolaser assisted cataract surgery for complex cases. So as you all know that femtolaser cataract surgery is the new kid on the block for more than a decade now. And in my personal practice, I'll be doing about 80% of my cases through the femtolaser assisted cataract surgery. Now, in routine cases, femtolaser cataract surgery obviously has a role, but the role gets exemplified or magnified, as one would wish to say, when you are working in challenging situations. So let's come to the first challenging situation, and that is the posterior polar cataract. Now let me just tell you that in posterior polar cataract, ever since we switched over to the femtolaser assisted cataract surgery, we have not had any nucleus drop, and I'll tell you why. This is the paper that we published in the Journal of Cataract and Refractive Surgery, wherein we have said that the in vivo image that you get on the OCT of the femtolaser helps you actually delineate whether there is a pre-existing posterior capsular defect or not, and then plan your surgery accordingly. So what is important is the imaging, and I'll just show you, this is an image of the patient. Even on the slit lamp, you can see that there is a huge posterior capsular defect. It's a polar cataract. Now let's see how we work on the femto. So you can see that when we are looking at the femto, there is a pre-existing defect. Can you see this? This is a pre-existing defect that is there. So what do we do? Because there is a defect, what we will do is that these buttons that you have, this is defining the lower edge of the nucleotomy. So what we do is that we increase them or take them upwards so that we leave behind a phaco safe zone. So we have done the capsulotomies. You have a fantastic capsulotomy. So if you want to place the lens on the bag, like in the sulcus, outside the bag, you can do that. You can see that this is the intra-op OCT. The intra-op OCT, as you showed, was having an epinuclear plate, but there is no dehiscence just now. So what you see here is that I have been able to take out the entire nucleus because the nucleotomy helped make it a very easy thing for us to aspirate. Now just see at the huge defect that is appearing. And now we put viscoelastic. You see this huge defect is there. You can see a blob of vitreous on the intra-op OCT, and you can go ahead and put the lens in the bag. So friends, what I wish to say is this is the photo essay on the same. You could see very much on the slit lamp, as you can see here, a pre-existing posterior capsular defect. You could see it when you were doing the femto. What you did was that you increased the default. You took the nucleotomy up so that you are leaving behind a thick epinuclear plate which will not be disturbed till the very end of the procedure. Even if you use the IOL Master 700, you could see this defect. So slit lamp examination, pre-op OCT also, and even IOL Master 700, etc., can let you know and caution you that there is a defect and you have to work accordingly. And this is the microscope integrated OCT. Again, you could see this is the huge fluffy matter which was going into the vitreous. And this is, once everything was cleared, you could see a blob of vitreous coming out. So friends, posterior polar cataract is something which is fantastically held, kind of done when you are doing a femto. This is a Malugan ring. If you have small pupils, you can easily work with a Malugan ring or a BX ring and do that. And this, thanks to Dr. Kumar, that's his video. You can see that this is a case where we are putting in a Malugan ring. And once you put in a Malugan ring, you can go ahead and do a femtolaser procedure. As you can see, we have dilated the pupil now, and we can take in and do the femtolaser procedure. And this will help us in this particular case to go ahead and do the entire procedure. So you can see we have a pre-chopped nucleus with the Malugan ring. People said, if you have a post-RK patient, you can't do a femto. All you have to do is that you have to try to make the energy higher. So what we do is that we make a higher energy, and you can see that it's a fantastic capsular access that is there. Rest of the procedure is about the same. Only if you are thinking that there is a problem, you should always use trypan blue so that you don't miss out any skip areas which can come below the incision. So a femtolaser procedure below a already operated RK is very much there. Now this is the case which was having a trauma, and we were doing a femto procedure in this. You can see that this, can you see this subluxation? This has a post-traumatic subluxation. When you are using a needle to do a capsular access, it is very difficult. But the femto will give you, irrespective of whether there is vitreous there or not, whether there is a subluxation or not, you can center the capsulotomy onto the capsular bag, and you have very little problem in removing the pre-chopped nucleus which is there. So subluxated cataracts, again, a fantastic tool that is there. This patient had a trauma. Because this patient had a trauma, he had a fixed dilated pupil. So we are doing SFT in this particular case, and you can see once we go ahead, do the throws, and we do two SFTs, top and bottom, you see how well the surgery has completed. So any subluxated cataract, polar cataract, these are my preferences of choice. If you have a patient with an ICL and developed a cataract, again, certain things in the complex cases, you can see here that this is the area where this is the lens, the ICL, but this can kind of mimic the anterior capsule, and you could see that the pupil was read as the optic of the ICL. So again, you have to be very careful that you have to bring the pupil up. And now you can see, I always put trypan blue because if there is any skip area, we can see that. And now go ahead, you can actually explant the ICL which was there. Once you have explanted the ICL, then it becomes a routine Phaco. So I prefer, again, a femtolaser procedure because you get a great capsular access in these particular cases if you are clear about where you want to go. Now this is a phacomorphic glaucoma. If you touch this phacomorphic glaucoma with a needle, you are 100% going to have, look at the intumescence of the whole thing, you are going to have an Argentinian flag sign. You can see that this is so near to the posterior part of the cornea. Just look at the huge explosion that came in, that is the fluid that came out. And you can see that because we are doing the capsular access on a closed chamber, please remember closed chamber phacoemulsification that you are doing, you get a good capsular access and you don't get a runoff of the capsular access. This is angle closure glaucoma. You can see this patient had angle closure glaucoma. Iridotomies were done, didn't help. Just see the thickness of the lens. You can see it's a huge thick lens that you have. The answer here is 5.8 millimeter. You do whatever you want to do, the pressures will not subside. Just go ahead, do a femtolaser, do a cataract surgery, see how the whole thing falls back and the pressures get controlled. You can see again the anterior picture, the huge difference that is there from the previous one. If you see this previous picture and you see the picture, and you see the picture now. This is the PI. So again, this is a treatment of choice because the chamber is shallow, everything is shallow. You can go ahead and do a femtolaser to relieve the problem. Rock hard cataracts. When you are doing a rock hard cataract, again, you can get a reduction in the phaco time that you have because as long as you can see through the hard cataract, just see the bubbles that came out, and you can see this is a black cataract, this becomes a pre-chopped cataract, and even in such black cataracts, you are able to actually do a Phaco procedure or a femto procedure with the pre-nuclear chopping that has happened. So friends, these are a couple of the cases which I would wish to bring out to you, that femto as a routine, fantastic, but the bar goes up the moment you are looking at difficult cases. And these difficult cases are, some of them I have shown you, where I would, even if I have to pay from my pocket, I will ask the patient to definitely go in for a femto laser procedure, because as the technology has advanced, and this has really taken things of the complex cases to a different ease that we have. And friends, I would say it's the time to take the leap of faith and switch over to the power of femto. So to conclude, there are several devices and aids which have come along with the femto. You use these devices and you are able to get excellent results. The only negative side is the costings that you have for buying the machine and per procedure cost. But I think patients are willing to pay, and if you can give them the guarantee of safety, you would be happier doing the procedure with femto laser assisted cataract surgery. Thank you very much for your kind attention. Thank you. Just any questions or any comments anybody has? Okay.
So I think, your point is well taken, and while there may be a lot of, critics of laser cataract surgery, but I firmly believe that in many of these situations which Dr. Maipal showed, I personally also feel that it adds huge value to both the quality of the surgery and the safety and the outcomes, and it definitely makes the surgery much more predictable and risk-free for the patient as well. And so there are several situations where I would, electively choose, for example, intumescent cataracts, pseudo-exfoliation eyes, and eyes with hard brown cataracts, posterior polar cataracts, RK eyes as well, where I would sometimes, there have been situations where I actually offered an upgrade to the patient where patient could not pay for it, and we absorbed the cost and yet we went. So that kind of, conveys that it does add a strong value to the procedure as well.
Thank you, Gaurav. We'll move on to Dr. Kumar. Doctor, as I told you, he's from Mumbai, a great exponent of and an early adapter of Phaco emulsification technique, and he has had the use of the catalyst as also the Zemer, but he'll be talking about managing the hard cataract. So the hardest cataract I've ever done. Kumar, over to you.
Thank you, Maipal, for giving this opportunity to me. And I want the panelists to look at this slide that I'm going to show and your opinion. And this is truly the hardest cataract that I've ever done in my career. So this is the right eye, and this is the left eye. So I tried all different slit lamps. I have an upper, I have a Topcon, and the maximum light that you put on your slit lamp and try to go through the anterior capsule, you can't see the posterior capsule. So you can't see the posterior convexity of the lens at all. So whatever you try, whatever instrument you try, you can't go through this, okay? So now the question here is, what will you do? Please remember this image because there will be questions asked at the end of it. So question here is, what IOL will you give? Of course, profession, night driving, whatever questions you want to ask. But will you do an ACC, SICS, ICCE, Phaco, or flax with Phaco? So panelists, if some of you have seen the image, I can show it to you. It's on the left-hand side. What technique will you use for this? Can 111 answer from that side? Shreyas? Or you'll refer to your neighboring best friend and make him your best friend forever?
I would still attempt a Phaco, sir. If it's, it's a well-dilated pupil, and if the bag is not too weak and pseudo-exfoliation is not there, then
no
it's likely that
good bag.
Likely that Phaco is still very much possible.
Maipal?
Flax.
Raghav?
So definitely femto, and definitely have a bigger access.
And Gaurav?
I would choose a femto as well, for sure.
Tityal, sir?
No, femto may be my choice, but recently, I've shifted to a pre-fragmentation with my loop and Phaco subsequently.
Great.
That's another option.
So this is the video that I'm going to show. I've hidden the name for a particular reason. But what is important to here to notice is that there is absolutely no glow coming from any angle of the eye. So you can see that there is zero glow. As you can see on the slit lamp, it was a very, very, very hard cataract. So here I've done flax, as some of you already believe in it. I'm now using the Z8 system, no financial interest. The advantage of that is we can increase the energy in each step. So if you have a very hard cataract, you can make your laser energy 120, 140. And if you have a softer cataract, you can reduce the energy. Obviously, more the energy, more the time, more the cavitation bubbles, etc. Now I'm under topical anesthesia, but remember one thing, when you have a very hard cataract and you have done flax, I prefer to use a dye. Sometimes you may not get a perfect CCC all around, and that can be caught on if you use a dye. So here you can see that I'm putting in the dye and making sure that the CCC is complete all around. And if the CCC is complete, and of course, you have to use a good viscoelastic. In this case, I've used Viscoat, which is understood. And at the same time, once all this is done, go ahead, remove the bubbles. Once that is done, make your main incision. And you can see that I'm making sure that the CCC is free all over. So once the CCC is done, now one battle is won here, because if case anything ever happens, we have the CCC to protect us. Now you are not going to be able to see your fluid wave at all, because it's a very, very dense cataract, which is understandable. So a very gentle hydrodissection. Make sure. Now again, in flax, the biggest advantage is you have a little bit of bubbles behind. So when we inject fluid, the fluid wave will find that bubble plane. So you actually have about 600 microns of cortex, in this case nothing, sitting above the PC, and this will help you in your hydrodissection. So flax does one big advantage, that it assists you in your hydrodissection, because the fluid wave will find that pneumatic plane. Once that is done, we go all around, and then we start our phacoemulsification. So you can see, again, the tip here would be to use a new tip. Use a brand new tip. If you already know that this case is going to come tomorrow, make sure that a brand new tip is autoclaved. You can see the shine coming out of the tip. That will help your phacoemulsification much more. Now, I've done fragmentation. In fragmentation on the Zimmer, we don't have cubes. We have two rings, or we can do sectors. So here I had done 6 sectors, which I normally stick to, or you can do 8 sectors. But the more the sectors you do, or the more fragmentation you do, the more time it would take. So here you can see that, of course, the best trick is to go deeper. Keep injecting viscoelastic. Once the viscoelastic injected, use the chopper, go all around. So here I'm going ahead and doing this. So again, you can see that it's easy to rotate. Once you can get your rotation quite easily, once again inject viscoelastic, make sure that you kept the endothelium safe, and continue to do your phacoemulsification. So here you got one fragmentation which we had gone through the flax, going ahead, holding the nucleus, and again I'm getting that groove which was done with the help of the femto, and then you can see the separation. Once that has gone around, I'm going to go all around this and then go ahead, and you can see it's a very, very dense nucleus. Once this is done, we still go ahead, go all around. I'd like to make sure that the central deep bowl is quite deep enough so that the hardest part of the cataract is really removed. Once this is all done, don't forget I'm under topical anesthesia. This is doing well. At this time, I'm going ahead and doing the last part of the fragmentation. Once I've made sure all the pieces are separate, again inject epitrate or adrenaline intracameral and viscoelastic. Protect your endothelium, go ahead and do your phacoemulsification and remove one piece. So you can see that I've removed first one piece. Once I made sure all the pieces are separate, once that is done, go ahead and do your phacoemulsification. Remove one piece, remove the second piece, and then that's done. And once that is done, you will see that there is hardly any cortex remaining. So you can see this, and once this is done, go ahead and do the last part of the phacoemulsification. So once we have done all of this quite easily, then do your bimanual IA. Now there is a reason why I'm showing you this, because there will be some questions asked at the end of the presentation. Do your bimanual IA and then implant an IOL. Now you'll be surprised, the IOL I implanted, I had never implanted this lens before. It is a Rayner EDOF lens, so I was just doing my bimanual IA, very little bit of cortex, and you can see that the CCC is good, intact. Inject again viscoelastic, make sure that you created your space, remove the subincisional cortex with the bimanual IA. Once that is done, we'll go ahead and inject the IOL in the bag. So here we are putting in the IOL, which is the Rayner EDOF lens. I've used Rayner lenses, but in this case, it was used for the first time. So now I'll ask a few questions, and that's what I will want an answer to. So you can see that the surgery is successfully completed. And of course, patient was very happy. The reason being he came back to me for the second eye. So we have some questions here. How old do you think this patient was? Quick, one-liner. Shreyas.
Considering that you're asking this question, I'm tempted to say 40, but normally I would expect it to be 75 or 80.
Yes, Raghav?
It's about 65, 70.
Maipal?
As old as you are.
I'm not going to disclose the age then. Okay, we skip that question. So, what do you think was the vision in each eye? You saw the image before, right eye and left eye?
So I'm presuming 618, 624 with a myopic shift.
Perfect. So patient was 618 and 624. How many viscoelastics you think I used in this case? 5. I don't get it free like you, Maipal. So I used 3 viscoelastic and BSS plus. One more question I want to ask. What do you think was the profession of this patient?
Did you chill the BSS?
Yes.
Profession of the patient?
Yeah,
he was an ophthalmologist.
Perfect. He's an operating ophthalmologist. Wow. And the Rayner lens was got by him. So I had no choice in lens selection. He said he wanted that lens. And before surgery, I met him in the pre-op, and he was taking a pill. And I asked him, what are you doing? He said, I'm taking Alprex. And after 10 minutes, his wife asked him, do you want another one? So I got tempted and saying, let me also take one. Yeah. But luckily, everything went fine. What was the first day post-op vision? He called me in the evening, so I was damn nervous. I thought there will be SK, striate keratitis, 660. And he said, no, I can see reasonably quite well. So his vision, surprisingly, next day was 6/9, and he was N8 and 6 part. And so he got his other eye also done. So I just wanted to say thank you, Maipal, for this opportunity. Thank you, everybody.
We didn't expect anything less from you. He is a great surgeon, that at least one can say. Any questions, anybody? So anyway, if you want to get your eye operated till his hands work, you can go to Kumar Doctor in Andheri. No charges.
Kumar, I have a quick question for Kumar.
Yeah.
Brilliant job as usual. You've used 2 femtosecond platforms now. You've moved on from one of the previous ones to the new one. What difference do you see, for example, in these challenging cases like this hard-brown cataract? Do you see a difference in the way you were using it before and now?
So I've used the Catalyst for almost 5 to 6 years, and now I'm using the Zimmer for 3 years. So I think subluxated cases, I think Catalyst, the softening of the nucleus, the Catalyst does a better job. You can't do cubes on the Z8. But as far as CCC is concerned, both platforms are almost the same. Segmentation, the big advantage I find on the Zimmer is that you can increase the energy. So if it's a very hard cataract, you increase the energy. If it's a soft cataract, you reduce the energy. So I don't know, I never tried it in the Catalyst. Okay, so you can do that in Catalyst, I just came to know. So that's another thing I found good. Otherwise, big advantage of course, between the 2 systems is the portability. So the Z8, you can shift from one center to the other or wherever you want, and it still does everything. So it's a all-in-one instrument which does everything.
For that, you'll have to make new centers. Anyway, I think...
excuse me, can I?
Sorry?
Can I question?
Yeah,
please? Okay.
sure.
Do you count the endothelial cell before and after?
Yes, we have a specular since many, many years, and we do specular for everybody. Yeah, we did count. The patient's fine.
Okay.
Did have a few spots. The patient knew, obviously, he had done his specular before also. But he knew about it. But because of BSS Plus and Viscoat, I was quite well protected, and patient did well.
Perfect. Thank you very much.
See, actually, if you do the Phaco in the proper plane, you don't do it supracapsular, and you avoid being nearer to it, and then you're using the chondroitin sulfate and you're using the femtolaser platform. These do very well. I don't know whether you were there or not, but I showed a harder cataract than this, a black cataract, and the patient did very well again. Patient was 6'9" next day.
Okay.
Okay.
Thank you very much and
Thank you.
congratulations.
Thank you. Gaurav?
Yes.
All yours.
Thank
so
you,
Dr.
Maipal
Gaurav,
sir.
you know, runs Drishti, great guy. And again, an early exponent for Femto and Phaco. And he's from Dehradun, and he'll be talking about pupil and iris issues, expanders and reconstruction. Over to you, Gaurav.
Thank you so much, Maipal sir, for including me in this course, and a very good morning to everyone for the meeting. So I wanted to share a few cases, and this is a 22-year-old gentleman with an injury to the right eye with a wooden stick. So he had a corneal tear with iris prolapse. He was operated at our center by one of our consultants where this repair was done, and the iris abscission was done, and then after that repair for the cornea was completed over there, and at the end it was well managed there. So going on, this patient went on to develop a month or two later traumatic cataract as well, and once the patient was out, initially he had fairly good vision and then gradually started deteriorating. Eventually patient was due for a cataract surgery, and this is how it looked. So there was quite a bit of iris tissue loss, and I was trying to imagine, so there is a big sphincter tear over here. So this is torn because that's where it was prolapsed, and there is also a lot of tissue loss here. And again, you can see the cut edge of the sphincter. So I was trying to figure out how I'll be able to repair the iris at this point, because while I do a lot of single pass 4-throw pupilloplasty, this would have required me to first, maybe suture this, and then we would still have a big defect here. And then I thought that this might not be a great case for doing a single pass 4-throw kind of a repair, because it's almost like 150 degrees of tissue loss. Now the topography showed very nice symmetric astigmatism, and so we thought we might use a toric lens, and we got this segment. We got several segments designed actually, so this is almost a 180 degrees. We got a 120 degrees design, and we got 3 different sizes done, because these are customized segments by one of the companies which does it for us. And when we then decided to go in with the surgery using a toric lens, we had a plan in place of implanting this artificial segment, and the cataract surgery itself was fairly uneventful. It was a soft cataract, and you can see here that it was just aspirated. And then now the challenge was that we had a 2.2 incision, and we wanted to implant that segment after the lens was implanted. There were 2 thoughts. One was to put that in the bag, but then we quickly realized that inside the bag there's not enough space to get this segment in. And we had done our homework by doing a literature search and finding that this can be nicely and safely implanted in the sulcus as well. And we had to enlarge the incision, because rotating this segment was not possible through a 2.2 incision. So we had to increase it to almost 2.8. And you can see that even with the 2.8, it was a challenge to push it through. And these implants are very brittle, and they can very easily break. So we had a standby implant as well. And you can see that finally, after a lot of manipulations, we were able to get this implant in and position it correctly into the sulcus. So there it now sits in the sulcus, and it's nicely closing the defect. So at the end of this, it started looking much better, because the IOL edge was fairly covered, and once the pupil came down, we could. This was the eye trace outcome. We had to use a toric lens of almost 3 diopters. You can see here a 3.2 diopters toric IOL implant was used. We got very good on-axis placement of the lens, and almost a perfect outcome as far as the astigmatism, even though this eye had undergone a corneal repair and there was obviously significant astigmatism. Patient did quite well. So this was a gratifying surgery, and of course these implants have that possibility of leaching pigment, but we've had a few of our patients over the last 10-15 years. We've not really seen a huge degradation in the quality of these implants, and they can be customized by one of the companies that we work with in India. So this was another patient. Now this gentleman had a fellow eye with a trifocal lens, and was very keen that in this eye wants of trifocal lens as well. But in this eye, as you can see, there was a situation with the iris being very unhealthy, and the pupil was drawn completely to one side, and there were adhesions here. So when dilated, this pupil looked more like this, and there was a cataract which was required to be operated. So again, the cataract surgery itself was not as challenging, and of course patient also had significant astigmatism. So going ahead with the cataract implants, cataract removal, we have been using this. The rexus tended to run out a little bit, so you can see that I'm just moving it to one side and doing the Brian Little's maneuver to bring that rexus back. under viscoat cover. So there I'm going to pull in the counterintuitive direction and the rhexis will be recovered over there. And you can see that I'm able to bring it in and then recover the rhexis. So then when, in these cases where you don't want all these things to happen, they tend to happen. So I was able to anyway recover that. And then of course the cataract surgery itself was fairly uneventful. Now we had to ensure that, when the pupil is in the normal state, the multifocal implant should not, the center of the implant should not be decentered as far as the pupil is concerned, because the pupil was totally pulled to one side, as you can see. So of course in the dilated situation it doesn't matter, but in the normal situation the pupil was quite pulled to one side. So we had to prepare for what to do. So we went ahead and now implanted the toric lens. This is a trifocal lens. Then we've gone on and done a sphincterotomy in the end opposite to where the pupil was peaked. It has to be very controlled, and after that we decided to see whether the lens is well centered. Now once that is done, we are going to do a pupilloplasty, because we want that the pupil from this side should not be as pulled to one side or peaked to one side as the other one. So here we are going to do a single pass 4th row pupilloplasty to recenter the pupil. So when using these implants, it's imperative. Now, if this patient was undergoing a primary surgery for the first eye, I may not have opted for a implant like this, but because the fellow eye was very nicely done, patient was plano 6/6, N6 in the other eye done elsewhere. This eye, in fact, the surgeon there had told the patient that for the second eye, he won't use a trifocal lens, and that's why the patient came, because he really wanted it. So you can see that at the end of surgery, frankly, the pupil looked much better centered. I did a little more sphincterotomy to recenter it after putting the suture, and in the post-op period, this eye looked like this. It's not beautiful to look at, but you can see that now the pupil is at least, ensuring that the IOL is well centered and the visual axis is absolutely clear. Otherwise, patient's outcome would have been unhealthy. Going to a third case, and here there's a big iridodialysis, and I'll close with this. There's a big iridodialysis, again a traumatic cataract with a firecracker injury, and we had to do a dialysis repair and a cataract surgery, and the lens was slightly subluxated as well over here. So putting iris hooks. This is important during cataract surgery to ensure that the pupil, otherwise the iris will start going into the phaco probe. So completing the rhexis and the cataract surgery, again, it's not a very hard cataract. Now this lady had previously, I put in a CTR. This lady had also had a previous pterygium excision done over here, and there was scarring of the conjunctiva. So in the area where I had to do the iridodialysis repair, the conjunctiva was not very healthy, and it was scarred on this side. So I had a situation to deal with, and we had a plan in place. I decided that I'll go with Hoffman's pockets, which don't disturb the conjunctiva. So after tightening the chamber and ensuring that the IOP is good, because we have to make those planes, I'll make a straight groove. And these are very elegant pockets that you can make. They don't disturb the conjunctiva. Also in patients where you're planning to do a glaucoma surgery later on or something, you don't want to touch the conjunctiva. Now here is where I go wrong. I've passed the suture, and without realizing, I'm trying to let it go through the pupil edge. And this is a horrible situation because it's like a horror story. I'm pulling so hard that there's a bleed and probably a little bit of more dialysis. So just watch what happens. And I keep going, and there's a bleed now. So then I'll show you how we dealt with it and how you can prevent all these things from happening. So there's a lot of learning, and you can see that the iris is now almost 180 degrees out of the dialysis has increased, and it's also prolapsing, not a good situation. So now we are kind of, railroading it, bringing it out, and then I'll go back with the needle as well. So the one lesson was that I shouldn't have released the iris hooks which were holding the iris in place. If I had those iris hooks in place as they were before, this would not have happened, because that would have kept the iris in place while I was passing the sutures. So while I managed this one, but for the second suture, then there was a lesson to be learned and then change to be made. So we made the second Hoffman's pocket. And you'll realize that now I'm going in a different way. You can see that I've only engaged the edge of the tear, and I've put a counter pressure using a bevel of the 26, and I'm railroading it right there rather than allowing it to be pulled there. So once you do this, you are ensuring that your iris will not move from where it is and you can pass your sutures very nicely. Today I see almost everybody uses this technique, and when I did this about 5-6 years back or maybe longer, this was something new for me, and it was learnt during this case, and of course after that I've been using this way of passing all my sutures for iris, and I mean most surgeons will reach the same place eventually. They'll improvise and find the correct solution. So this is a third suture. So eventually we had a good repair done, and this is the third suture. Eventually patient also had a nice looking eye and a nice symmetric round pupil. So this is how it looked at the end. And I think patient, we have a post-op picture as well. Sorry, I think it was right at the end of that video. So this is how it looked at the end, and next day post-op patient was 6/6 unaided almost, and you can see it was better vision than the fellow eye, so we had a very good outcome. Thank you so much.
Thank you very much, Gaurav. I think we'll just reserve the discussion for the end. I'll just go on to Dr. J.S. Titial, again an excellent cataract surgeon, and he'll be talking about phacoemulsification in posterior polar cataracts.
Good morning, friends. Thank you, Professor Maipal, for giving this opportunity in instruction course. I'll be talking on a posterior polar cataract management. You all understand the basic aim in any cataract surgery, including posterior polar, is to have a safe surgery, that is phacoemulsification. And in posterior polar cataracts, understand the very, very high risk factors which can predispose the case for a PC dehiscence happening during the surgery and prevent complications which may be associated with these cases. No financial disclosure for this particular talk. Let me show you how to do a safe emulsification in these cases. This is a typical posterior polar cataract. OCT picture gives you an assessment of a posterior part of a posterior capsule nearer to the posterior disc of a posterior polar cataract. The capsular axis size should be adequate, around 4.5 to 5 millimeter. Hydrodelineation has to be done, avoid hydrodissection. You can see in the AIOS2025 microscope the classical delineation of a nuclear core from the epinucleus. If you have a viscoelastic, have a cushion for an endothelium. Subsequently, you can do a safe chopping of the nucleus without too much of disruption of epicortical cushion, which is created by the hydrodelineation, and play in a manner which is safe. That means your phaco parameter has to be adjusted, no fluctuation to be seen. Epicortical cushion has to be removed towards the end, and make sure you don't create this. This is called pseudo defect, which we have described this as a posterior polar cortical disc defect. In fact, this indicates your posterior capsule is intact. You'll see in the OCT picture subsequently. You can see the cushion is still intact. I'm removing the last bit of cushion here. Subsequently, without decompromising the anterior chamber dynamics, you can aspirate the cortex. This I'm aspirating with the handpiece itself. Remove your second hand, fill with the viscoelastic. Don't let chamber collapse, and implant the IOL. You can see very nice integration of the position of IOL, which is stable, and the PC is intact. And that shows your surgery has been perfect in these cases. But it is very important to understand, before you jump for surgery, what are the risk factors which can be imposed on us. So these are various presentations of posterior polar cataracts. In a just real-time examination, sometimes not very, very clear, which are those cases where you have a posterior capsule weak in these cases. In that way, I think, apart from the examination, anterior segment OCT, if you have a AIOS2025 microscopes, all these features will point towards the high-risk features. So this you can see a reduplicated type of cataract, and the size is also important. If the size is more than 4 millimeter, then it's a high-risk case. And this is what a classical feature of pre-existing defect, where you have a whitish granulation just behind that in the anterior vitreous phase. And the hardness of nucleus is also very important. Harder the nucleus, you have more chances of damage happening in these cases. This is what we published in JCRS, the assessment of these cases with the anterior segment OCT pre-op, and this 100 sequential cases we scanned with the OCT, and we realized these are 3 important morphology in your OCT assessment which can be a high-risk factor. The first is the conical shape on a posterior polar cataract. Second is the moth-eaten appearance. And third is the eclectic morphology. If you have these three morphology in your anti-segment assessment, these are high-risk cases. If you see here, these morphology are seen in around 10% of cases, and they have very high risk of opening the posterior capsule during your surgeries. Rest 90% cases are conventional or a generalized morphology of posterior polar cataract, where chances of PC opening is very, very less. You can do a routine surgery in these cases. So these defines the way of you approach your surgery in these cases also. The other thing which we published in a same journal as a similar article is to assess these cases with the AIOS20 microscopes, where we classified them in 4 categories: type 1, type 2, type 3, and type 4. Type 1 were those cases where you could delineate the posterior capsule throughout the length of posterior polar disc. And type 2, where you could delineate the posterior capsule in the periphery, but in the center you could not delineate the posterior capsule, and these have a high risk during the surgery. Type 3 is, as you saw in the anti-segment OCT, moth-eaten appearance, where you can't really delineate the capsule throughout the posterior polar disc, and these are very, very high risk factors. Intraop OCT also gives you assessment of seeing what happens during your hydro procedure and subsequent Phaco also. And that gives you assessment. This is a delineation which I have created. This is the endonucleus, and this is the epicortical cushion, and PC is intact in these cases. And that also gives you assessment how effective your hydro procedure is. The other way to look into to manage the nucleus in a safe manner where you don't have the damage. Therefore, safe nucleotomy is the way to go about. As we classically say, avoid cortical cleaving hydrodissection in the posterior polar cataract. Do not rotate the nucleus. If you have these two things to be done, the nucleus management becomes difficult. There, I think the technique we described, chop and tumble technique, is very, very effective in these cases also, where we delineate the core of nucleus, no rotation is done, and subsequently procedure can be completed by playing in the middle without disruption of a cushion which protects the endothelium. This is a video you can see here. I'll do a little trench in the central area. This is a grade 3 plus nucleus. Once I hold it, I'll chop it in the center. This is a primary one chop. I'll go towards, you can't rotate now, towards the left, make one other chop. You have a pie of a nucleus. Take out this. This gives a space for an internal hydrodelineation to separate this nucleus further. And subsequently, you can just tumble the nucleus to the center centripetally, and you can manage this case without the rotation or disruption of epicortical cushion, which may be attached to the posterior capsular disc. And this prevents the rupture happening during the initial procedure of nucleotomy, and that safeguards the case for subsequent management. Now I'll take out the epinuclear cushion. First pull out from the periphery to center, then you take out in a bulk, so that even you have a tear, it will not disrupt the anterior vitreous face. And this is how you complete the surgery effectively in these cases also. The chop and tumble technique seems to be very, very safe in these cases. Just another demonstration with AIOS20 microscope. This is a primary chop I have done. I've placed a space here, and this space gives you a fluid to redelineate the endonucleus in these cases. And that also improves the subsequent movement of a nucleus, which is managed very effectively also. And this technique is very useful in a pre-existing PC defect also. The other area which can be very, very effective is using the femtosecond laser device in a posterior polar cataract. And this hybrid technique, which we published in a Journal of Refractive Surgery, where we create the 3 zones of a delineation, Phaco delineation, and 8 chop. This is a Lensex platform, which gives you a very nice way to handle these capsules. And this OCT picture which Dr. Mahipal talked about, you can always assess the case also, and in fact, you can diagnose the pre-existing defect also. There we can have now primary segment, secondary segment, tertiary segment, and without rotation, without chop, you can take out. No hydrodelineation done. This is a separation. I'll take on the primary nucleus block. And this is the block by block disassembly of nucleus can be done very effectively, and no rotation done. Your second hand takes out the pieces effectively and managed very, very comfortably. This is like a representation of the Phaco you do with the chop and tumble technique with the femtosecond laser. And in this way, you can prevent major damage, and very effective in cases where you have a pre-existing defect also. I think to summarize the entire posterior polar cataract, we need to do a very, very comprehensive pre-op assessment. Still-time examination, dilated pupil is very essential. Anti-segment OCT is essential now for all cases of cataract, not only posterior polar cataract, wide cataracts also. But if you have access to AIOS20 microscope, that gives you intra-op dynamics where you can really see what type of delineation you have done, and if there's a posterior capsular dehiscence happening, go for a safe nucleotomy in these cases. And if you can go see this PPCD defect sign, that indicates your PC is intact in these cases also. But if you have a femtosecond laser device with you, you should use that. That will decrease the complication in these cases also. Thank you for your kind listening, and thank you, Dr. Mahipal, for including me in this instruction course.
Thank you, Jeevan, for an excellent talk. Any questions, comments from anybody? I think he has again highlighted the efficiency of the femto platform for handling posterior polar cataracts. I think with the advent of femtolaser, the complication rates has gone down. Yeah, go ahead. Significantly with femtolaser. Yeah.
Hello, sir.
Yeah.
In posterior polar cataract, whenever we are dealing with very dense PSC,
Yes.
even after IA have been completed, a central part of opacity is there lying inside the defect.
Yes.
So whether to leave it for further YAG or whether to take it by posterior capsular polishing.
I think that's a very important point raised by you, and we do see some sort of a granulation or fibers there in a central part of posterior capsule. It is better to avoid to delineate that because you might open the posterior capsule at that time. Put your IOL safely. If needed, you can always do a YAG capsulotomy subsequently. And the visual acuity for these cases are quite good in the initial period. It may require a YAG to be done after a few months or few years. So don't jump for a taking away. But if it is a fibrosis, which may not be a posterior polar cataract because of some reasons, it is a thick fibrosis, you might tackle that on the table because visual acuity may not be good in these cases. So one way is implant the IOL. You can subsequently do a vitrector cutting the posterior capsule, or you can do a PCC in those cases if it is not a posterior polar cataract. If it is a posterior polar cataract, you touch, it will open up to the periphery. So be careful.
Thank you.
Thank you. Anyone else? Yeah.
Good morning, sir. Very wonderful insights. I just wanted to know how common is to, generally we see that the PPC is generally seen like with softer cataracts like NS1 or almost insignificant. How common is it to find like nuclear sclerosis 3 or 2 or plus with PPC?
I think, very good observation. If you have a younger patients, like there you normally see a softer cataract because these people come earlier because these posterior polar cataract are visual axis and they have a lot of visual problems. It is an adult onset type features of posterior polar cataract. Sometimes they come quite late, especially one eye has been done and they see well. A second eye they wait for longer time. You might see a nuclear sclerosis in these cases also. The percentage of such cases may be around 10 to 15 cases of all cases of posterior polar you deal with. But those are difficult cases. I've had a series of cases where patient had come as a hypermature state, and as soon as you touch, the nucleus goes down. And there, it is very important to examine the other eye also, because other eye will give you a lot of telltale signs of, either a complicated surgery or a posterior polar feature may be there in these cases also.
The lens is in back or it was placed.
So if you suspect something, if you don't see, go up to the posterior capsule with the OCT picture, you might do the UVM in these cases, which might give you features of little bit of, you can say, spots behind the posterior capsule. That may be a feature for a posterior capsule opened up.
And what technique of nucleotomy will work in this? Like, will this chop and tumble work in this heart?
Definitely, because you are saving the epinucleus there. So that's a very good technique in those cases.
Thank you so much, sir.
Thank you so much. Thank you, Dr. Titial. What he said is absolutely, especially if you are a good surgeon like them and you're getting patients referred from elsewhere and you see a bad surgery done in the other eye, the patient won't tell you that he had a posterior polar or he had a nucleus drop. This happened to me once and I just did a normal thing. I said, "Theek hai, whatever." So just did and immediately it went in. So you have to look at the other eye and then ask pointed questions. Specifically, this is for surgeons who get referral cases. Thank you. We have now the pleasure of inviting Dr. Chang. As you all know, he's one of the most influential ophthalmology, I think ranked 5th most influential in the world. He has several books to his credit. He practices in the LA area and a great friend of India, but everyone loves his videos and his teaching specifically in cataract surgery. So over to you, sir, with your talk on Phaco with zonulopathy, your 6 best pearls. Thank you.
Well, thank you so much. It's certainly an honor to be here and to share the stage with this all-star faculty from India. No financial interest in any device. I'm going to give you my 6 best pearls for diffuse zonulopathy. Enlarge the CCC diameter, go to capsule retractors early, take advantage of this spiral CTR injector, use a dispersive to put the posterior capsule on stretch. Think about a 3-piece IOL sulcus with optic capture, and don't be late to convert to a manual extra cap. So let's illustrate this. You know, it's not enough just to get the lens in the bag. We have to prevent this complication of late bag IOL dislocation, and we have to think about that. Zonulopathy often forces us to make a smaller rhexis just to complete it, but the key is don't leave it there. You can make an oblique cut and then re-tear it, sort of a secondarily enlarge it. When you see capsulophimosis, it's always when there's diffuse zonulopathy. And what that tells you is that that rhexis kind of acts like a sphincter. It wants to constrict. And what stops it from constricting this much, in every case, is the centrifugal tension of the zonules that are resisting that. And that's why making that rhexis larger when you have pseudoexfoliation will really help to prevent that. Now, if you're not comfortable with that, you can make little relaxing cuts in the edge of the rhexis. Just think of it like a capsular sphincter, and you won't be leaving it too small. In this particular case, I'm actually tearing it out to the edge of the optic. You don't have to go that far, but the larger you make it, the less it will want to contract. And of course, you get into this vicious cycle where it contracts more, and then that tugs more on the zonules, it contracts more, and that's how you end up with this serious capsulophimosis. Now, pearl number 2, these are capsule retractors, and they are going to be artificial zonules. They're going to give you counterfixation to the bag in a way that a CTR will not. So when I know from the rhexis that I've got diffuse zonulopathy, I'll put this in before I even rotate the nucleus, because when you rotate the nucleus, you need counterfixation of the capsular bag to prevent that action from tearing more zonules. These are from Microsurgical Technologies. It's the Chang version. I have no financial interest. And be careful not to tighten them. This is not like iris retractors where you want to put this on stretch. And remember that with the infusion, everything moves back a little bit, so sometimes these can be too tight. But you can see how this also keeps the peripheral capsular bag from being aspirated into the phaco tip. It restrains that, and it supports it in the AP direction while giving that counterfixation, letting me rotate the nucleus. So you want to delay putting in a CTR and use these to fixate the bag during the phaco. All right. Now, look at me trying to put in the CTR. I know it's going to decenter the bag, and this is, look at the zonular dialysis. There's no zonules down and to the left. My goodness, I cannot get this in. If I persist, I'll dislocate the whole thing, and I have to come out. This is a dead bag syndrome. So this is a great innovation from Dr. Shimawaki of Japan. The one hook retracts the one eyelet, and the fixed little hook bends the lead eyelet. So now when I go in, instead of having the capsular bag and the zonules being what bends the CTR, it bends automatically. And all that tension in the CTR is borne by that fixed hook rather than by the capsular bag. And then you just tilt it a little bit and it will drop in there. You can see it's available through Corza and Katina. Great invention by Dr. Shimawaki. When you have capsule retractors, this can be hard because the eyelet can get tangled in the retractors. The bag may be lax in those areas. So you can see here how this nicely allows this to unfold and basically avoids trauma, further trauma to the zonules from the actual insertion. Sometimes it doesn't fall off. I'll use a second instrument to knock that off. Now, look at the posterior capsule. I know it's a zonulopathy. I'm trying to guard with my chopper, and I move it just right there. And you see I aspirated that. Why did that come up so quickly? And there, you can kind of see in the middle, I have a puncture in there. So what I should have done is stopped around this point and filled the bag with dispersive. What's going on? Normally, zonules keep the posterior capsule taut. But if the zonules are weak, there's a lot of laxity in the posterior capsule. So it flies up to the phaco tip when you're not expecting it on your low epinuclear setting. So instead of proceeding, when you fill the bag with a dispersive OVD that resists aspiration, it puts the posterior capsule back on stretch. Here's another case where I'm doing the same thing. So it's not just that you're moving the posterior capsule back, you're stretching the bag in the absence of the centrifugal pull of the zonules. And so here you can see how there's some viscoelastic to your left still. That's because it's a dispersive and it stays there. Now, I have the same problem. The posterior capsule is not anchored. It's not taut. So it doesn't want to separate easily from the cortex. I have to be so careful that I don't tear or aspirate the posterior capsule. And yet I don't want to put a CTR in now because that's going to trap things. So I pause and I put in a dispersive, again, to resist aspiration. And it's putting that posterior capsule on stretch, like as though the zonules were strong again. And now see how that cortex separates easily. Biaxial INA is a great choice here. And then if you don't use the spiral injector, see how I aim the CTR injector tip to the left so that it opens to the right and doesn't displace the bag. Now here's a case where I did all of these things, and after putting a CTR in and a three-piece in the bag, I've got terrible pseudophacodenesis. So now what am I going to do? Well, I can't leave it that way. So maybe I can put it in the sulcus. Maybe I'll need to suture the haptics to the iris. Well, I enlarged the rexus, as I showed you earlier. So getting this from the bag into the sulcus, not so easy. This is an older case, but it's one that taught me a lot. So I have to bring the lens into the anterior chamber. And then one haptic at a time, because of the posterior angulation of this lens, I can get each haptic under the iris, but in front of the anterior capsular rim. And here you see the fact that I'm able to rotate and displace the lens so much shows it's in the sulcus. Okay, so now here's the question. What happens? I shake the eye, and it goes from jiggling to being absolutely still. So this was the index case that taught me this, because this is the same lens in the exact same eye, but I'm comparing two locations, in the bag and in the sulcus. And the conclusion is you're getting extra haptic ciliary body fixation, as though it was a ciliary body fixated lens by not relying just on the zonules. Now here's a case with a zonular dialysis nasally. I've got my retractors then, and so I'm going to do the same thing. Now here I'm going to put this in the sulcus. I don't want it to rotate into the meridian where the zonular dialysis is, and I'm going to capture the optic. Before I do, I aspirate some of the viscoelastic behind the IOL, because remember, we're trapping the optic in the anterior capsule, and this prevents contraction of the rexus, it centers the lens, prevents rotation, and I don't have to adjust the IOL power. Finally, here, look at, this is a dense lens, and look at how much phacodenesis I have just to complete the rexus. And our younger colleagues who aren't experienced in extra cap really should learn how to do this, and we should do this more often. And that is what? I'm making a can opener, I'm moving superiorly, converting to a manual extra cap. If you're really confident in SICS, you can do that, but this is not the time to practice it or learn it when you have this kind of giant lens. And why do I say that? Well, this is going to be much better for the cornea, and certainly we can preserve the posterior capsule so we don't have retained lens, but also I'm not going to have to suture fixate the bag with some kind of sutured element, because this lens, it's a three-piece, you know, one of the haptics probably going to end up in the sulcus, and this will never dislocate. So I've got great fixation. The only thing is I have some sutures in an eye that was horrible preoperative vision to begin with. So this is an underutilized technique, in my opinion. So these are my 6 pearls. They're not things that we're all used to doing, and I hope this is helpful to you. Thank you very much.
Thank you very much. Indeed, great learning for all of us. Any quick comments? Thanks. Okay, we go on to Dr. Shreyas Ramamurthy. He's co-heading, I would say, the Eye Foundation Group, and again, a great cataract and a cornea person. So a mixture of both these problems, having a cataract and a hazy cornea. So Shreyas, over to you for your talk on phacoemulsification in hazy corneas.
Thank you so much for the opportunity. And today I'll be taking you all through a series of situations where we have a compromised cornea. While a compromised cornea could be something as simple as a dry eye, to something where measurements might be difficult in a case like a very irregular astigmatism, or a cornea with a poor endothelial count, or corneas where the view itself is compromised because of opacity, graft-related issues. And I'll quickly run through some of these indications and try to convey some select points in each of these situations. Now, the first and most important and the most common problem that we would come across is an ocular surface issue with a dry eye. Now, the problem with this is that very often the patient's symptomatic will be more than out of proportion to the cataract, and it's also the measurements which become very, very difficult. Repeatability in biometry drastically goes down when you have a surface which is broken down with multiple punctate erosions, and it's important that we treat this eye with lubricants, with medications, with possibly a short course of topical steroids, and then repeat the measurements on a pristine eye. You can see that almost 3 diopters of astigmatism, which was there in the first measurement, is now completely gone once the cornea had cleared up. So it was essentially an erroneous measurement, and if you went ahead with the toric IOL, you would definitely have suboptimal results. So essential to treat the dry eye and ensure that the biometry is the first investigation that you do on the patient's eye when they are coming on the review visit, when the cornea is clearer, is extremely important. Going on to a more extreme situation. Now, whether it's a basic dry eye where you're stabilizing the surface, or in these conditions where Stevens-Johnson syndrome or ocular cicatricial pemphigoid, or even an advanced Sjogren syndrome, it is important that we give adequate immunosuppression in these eyes and ensure that the surface of the eye is stable before you take them up for surgery. In this particular eye with Stevens-Johnson syndrome, the keratinized lid margin was abrading against the cornea, causing repeated breakdowns. And even though the patient had a total cataract, it's important that you stabilize the surface. Now again, while the lid margin might have been stabilized, the fornices might still be shallow, so you may have to resort to traction sutures. You may not be able to put a speculum in. And in these eyes, it's important that there will be some opacification. We are obviously not aiming for emmetropia in these patients, trying to give them the best quality of vision that they can have. So we have to alter our phaco techniques according to the situation. Slightly tilt the globe towards the side where you have better visibility. Complete all your chopping maneuvers in the opposite side of the eye. You can see there is a slight paracentral opacification, but obviously these eyes are not patients where you would want to ever do a graft. Also remember that the corneal tensile strength in these eyes is lower, so even though if you've made a good incision, still it's better to suture the wounds. The healing does take a little longer, and these patients are more prone to postoperative corneal melts and a thinner cornea. Subsequently, you can always do a scleral contact lens fitting in these eyes, and once the cataract has been removed with the scleral contact lens, the patient had a 6/12 vision and a good outcome. Keratoconus is again a very common condition that we encounter in our country, and it's important to differentiate whether the patient was a previous contact lens user or not. If the patient was happy with contact lenses and is willing to wear contact lenses in the postoperative period, it's better that you stay away from any kind of toric IOL. Because once the toric IOL is in place, you have the contact lens, then it will uncover the astigmatism corrected by the toric lens, and the patient will have to wear spectacles on top of that. You can also optimize the surface before the cataract surgery. You could either do a topography guided PRK, improve the symmetry, because if you're planning to do a toric IOL, it's important that you not only have repeatable measurements in terms of magnitude, but also the direction, that the vector of the treatment is also repeatable across 2 or 3 different devices, and only then go ahead with the surgery. Even intacs could also be done, ring segments could be done to improve and better center the cone before going ahead with the cataract surgery. This is cataract itself is fairly straightforward, but it's important that these things are done prior to the cataract surgery before we go ahead with the surgery itself. Aim at a slightly myopic outcome, give room for either doing a piggyback IOL if the patient has a significant residual error, using some modified formulae for keratoconus like the Kane keratoconus formula is definitely improving results even in these keratoconic eyes. Very advanced keratoconus with significant scarring, you would want to do a DALK first, and once the patient has undergone DALK and there's a time period of 6 to 12 months which has elapsed, suture removal has been done, and the patient has a stable and repeatable astigmatism and stable topography, repeatable topography, you can then go ahead with the cataract surgery. However, these eyes may still have a significant amount of astigmatism, and you can customize the toric IOL, and this is a 9 diopters of cylinder being corrected with the toric IOL with the customized lens. Again, we are not aiming at emmetropia in these patients. You are bound to have some residual astigmatism, some irregularity, some shift in axis even in these eyes. But the best corrected visual acuity and the spectacle corrected visual acuity improves significantly once we debulk the astigmatism in these situations. Again, in the setting of trauma, it's important that we time the surgery appropriately, that all the sutures are removed and the eye is stabilized. Even if the patient has a significant cataract, it's perfectly all right to wait, because once the visibility improves, it definitely makes the cataract surgery easier. You are bound to have some fibrotic membranes and synechiae. It's very likely that the trauma has compromised the capsule, not just anteriorly, but also posteriorly. So avoid a hydro dissection in these cases, keep a 3-piece IOL standby, and gently tease out the cortex and epinuclear sheet, because there is a very high likelihood that what is pierced through the anterior capsule might have also injured the posterior capsule. So being ready for these situations is very important. Ensuring that suture removal has been completed is important in terms of your biometry. We may have the opportunity to wait in many cases, but unless in some of these situations where the intumescent lens is causing peripheral anterior synechiae to form, there is increase in IOP, in those situations you may have to intervene a little earlier. Patients with a poor view, where you have a failed graft, where you have to combine it with an endothelial keratoplasty, to do a safe phacoemulsification, you can temporarily deturgis the cornea with glycerol. You can use chandelier illumination as well. While this chandelier illumination helps us to have a better red glow and do a safe in-the-bag phacoemulsification, complete your chopping maneuvers while you're doing the cataract surgery, having a IOL in the bag is also very useful for your subsequent bubble maneuvers when you're doing your endothelial keratoplasty. Because if your IOL is kind of moving around or dancing around, it's less likely, there's more chances that the air bubble might escape behind the IOL, push it forward, and thereby compromising the surgery where you're pushing your lenticule in place with a DSEC, or more difficult so if you are doing a DMEC. In these cases with a failed graft with poor visibility, we would prefer doing a DSEC procedure. Again, a simple push-in technique. While this is a large therapeutic graft and therefore I'm making an incision through the graft, but in most other situations we would do an incision which is peripheral to the graft. Moving on to a situation now, it's not just visibility that grafts will give you a challenge in. You may have issues where the cataract is a little denser, the pupil doesn't dilate very well. You have some iatrogenic damage which might have been caused during the initial therapeutic or the optical penetrating grafts. Now, it's important that we follow good principles, safe principles of phacoemulsification, have iris hooks in place. Ensuring that the iris doesn't come into the wound is very, very important, because automatically in those cases, your phaco will become a little more anterior. Now, that's reasonably okay with a patient in a normal cornea, because you'll just end up with a little bit of stride keratopathy. But in a graft like this, that will lead to the failure of the graft itself. So ensuring that we take adequate care and precaution in having a well-dilated pupil with iris hooks, keeping the iris away from the incision, making a tunneled, beveled peripheral incision to ensure that the iris is not prolapsing through the wound is all important steps. Of course, needless to say, you'll be using some viscoadaptive devices to ensure that you protect the endothelium during the surgery, do the entire phaco within the bag itself, and you can give excellent outcomes in these patients as well. Toric IOLs can also be used in these patients, especially if the patient has a repeatable topography and the astigmatism is fairly stable. Now, running you quickly through a couple of situations where you would not want to do a combine it with a penetrating keratoplasty, where this is a patient with an adherent glaucoma. While the visibility is poor, you must remember that the patient has been seeing through this part of the cornea for the major portion of their life. This is an adherent glaucoma from childhood, and this is a case where you're likely to also encounter a significant amount of neurotrophy, and in any of these situations that trying to do a penetrating keratoplasty can have disastrous results. Quickly showing another example of a patient who presented with a bacterial infection, resolved with scarring, has a stable surface now, but the other eye had a failed vascularized graft. Now, it would have been tempting to do a combined triple procedure. Doing a PK with a cataract surgery in this patient would have been an easier surgery as well. But then this patient had a significantly neurotrophic cornea. So again, if you do a penetrating keratoplasty, it's only a matter of time before we end up with a failed vascularized graft like he has in the other eye. So the alteration that we would do in this is ensuring that you complete your chops adequately, tilt the globe towards the side where you have visibility. It's important that even though it's a dense cataract, you break it down into multiple pieces before you start evacuating the pieces, and then only once you are able to do that, you start removing the pieces, because you don't want to create any kind of zonular deficiency in these eyes, which makes the surgery even more challenging. The last is just to say that not every time would you have to combine. This looks like a graft which is going in for failure, but this was a patient with peripheral anterior synechiae, raised pressures because of the phacomorphic glaucoma that he had, phacomorphic glaucoma and the intumescent lens that he had. So just doing the cataract surgery and removing the lens and controlling the IOP made the graft clear, and the graft remained clear for a period of 3 years, before which an endothelial keratoplasty was required. So it's not always that you may have to do a combined surgery, and very often just doing the cataract and controlling the intraocular pressures ensures that the cornea clears up. Thank you so much for your kind attention.
Thank you very much, Shreyas. Excellent presentation, great bouquet of cases. I think we are running late. We'll go on. Normally it's the son following the father, but here it's the father following the son. So over to Dr. Ramamurthy. As you all know, he's past chairman, scientific committee, past president, AIOS, and chairman of the very successful Eye Foundation Group. Ram is going to talk about management of deficient capsule.
Thank you so much, Dr. Mahipal, for this wonderful opportunity to be a part of your great course once again. And I think the immediate goals for managing a deficient capsule is to extract all of nucleus, remove the cortex and the epinucleus as much as possible, do an adequate anterior vitrectomy, preserve residual capsular support, and just in case you are sure that the lens is going to be stable, go ahead and implant an IOL. The last aspect is the least of the problems. It's most important that you do not damage the eye irretrievably. And just in case a significant amount of nucleus or lens matter has dropped into the vitreous cavity, it's better to enlist the support of a posterior segment colleague. So let's look at these bunch of videos. This case I did about 25 years back. He was a physician from Ooty, As you can see over here, I had the primitive instruments. I have a large PC rent over here. You can see the anterior vitrectomy being done. Basically, the principles are remaining the same. We did not have triamcinolone acetate. I just use a Vexel sponge to make sure that there's no distortion of the rhexis margin or the pupillary margin. That tells me that the anterior vitrectomy is quite adequate. That's a 3-piece lens going into the sulcus. At that time, we did not have the concept of capsular capture that Dr. Chang talked about. So basically, I'm placing it in the sulcus there and then creating an adequate rhexis capture. It's essentially an optic capture that I'm doing. And whatever little strands of vitreous are there, are again being taken care of. You can see the fairly large tear over there, but then that's the end of surgery. And this is what the patient had on the table, and this is what we ended up at the conclusion of the surgery. And mind you, this was done about 25 years back. And he continued to follow up with me. This was taken about 21 years back. The gentleman passed away a couple of years back, bless his soul. Until the end of his life, he maintained an excellent visual acuity of 6'9". We continued to be great friends. And obviously, this is just to drive home the point. Just in case you have a deficient capsule, all is not lost. As far as you use the basic principles of management of these cases, quite often you are able to retrieve excellent results. In the bag implantation with PCR, you can see all these videos are running at 2x speed, so that's the reason the bit of it's a little jumpy. A little hard cataract, basically what I'm doing is a direct chop, and all the maneuvers seem to be going quite well. My Phaco probe remains steadily in the center, the nucleus fragments are flowing in, but then as I proceed with the surgery, as was pointed out earlier, there was a surge, and I do have a PC rent, which will become a little more obvious. It's right over here, and you can see in this area. And essentially, without the chamber collapsing, I inject dispersive viscoelastic to tamponade the anterior vitreous face. Then subsequently, the vitreous has not yet presented. I inject more of HPMC on top of it. Having inflated the back quite adequately, this patient was to receive a trifocal toric intraocular lens. The lens of my choice is being injected. The Varion display is on all the time, though it's not being shown up on the video. You'll see it towards the end. So without disrupting whatever support of the capsule that is there, and with this lens going into the back, premium intraocular lens, I'm able to maneuver the haptics inside also, and then position the lens exactly according to where it needs to be, evacuate the viscoelastic quite adequately. Obviously, since dispersive viscoelastic has been injected, it takes a little time to remove that. And then, of course, inject a little bit of triamcinolone acetate to make sure there are no vitreous strands over there. Now we can see the digital overlay and the lens being exactly in the position that I want, and this significant PC rent over there. So just in case you have an adequate amount of PC support, in spite of the PC rent being there, it's possible to go ahead and implant the intraocular lens in the back with no compromise in the results. This is a basic concept all of us have to understand, in the sense that when you are doing an anterior vitrectomy, go ahead and have this cut IA mode on, where you cut the vitreous strands and subsequently aspirate. And in case when you comes to removal of the cortex material, you need not really exchange it with an aspiration cannula, but go ahead and have the IA cut, where you essentially aspirate the cortical matter, or you can just have the settings of the irrigation aspiration with the vitrectomy probe in place and then continue to function. The most important aspect is to have the highest cut rate that is possible in your particular machine that you're using. All your other parameters, the intraocular pressure, the vacuum, the aspiration flow rate, etc., has to be quite minimal and well manageable. You want the least amount of turbulence and the most controlled surgery that's possible. And what about PCR during initial chopping itself? This again is a fairly routine case, a walk in the park case. But what I noticed during my here, I have a PC rent, and what I do is to immediately tamponade the anterior vitreous face with dispersive viscoelastic, bring whatever nucleus fragments are there into the anterior chamber, and then with adequate covering of the endothelium, I go ahead and remove the nucleus fragments over there. You can see the fairly large rent over there, and once again I inject dispersive viscoelastic. The vitreous face is broken, but the idea is to remove as much of the nucleus fragments as possible before I go ahead and do an anterior vitrectomy. And now I go ahead and do the anterior vitrectomy where the basically irrigation cannula is separated, and through the side port, the vitrectomy is done, and then subsequently removal of the whatever cortical matter is there. It's invariably in these cases, there could be some lens droppings, and at the end of the a week later, I would always have my vitreoretinal colleague to examine these patients to take care of it in case it's necessary surgically or follow them up closely. Then subsequently, it's a 3-piece lens that is going in. Whenever you have a situation like this, it's always a good idea to place a lens in the sulcus and then create an optic capture. And as I showed you in the first case, you can get an excellent results without any compromise. So it's a fairly large lens that I had right in the beginning of the surgery, but with proper management, with proper usage of dispersive viscoelastic, moderate parameters, we are able to get the kind of results that we need. And then in case you have significant nuclear remnants still there and your anterior vitreous space is intact, I found this IOL scaffold technique, which was essentially brought up by Amar Agarwal, to be quite useful. This, you can see the one heminucleus is being removed quite completely. But before I reach out to my second bit of the heminucleus, I find that there is a fairly large rent over there. So essentially what I do is to bring the second nucleus fragment into the anterior chamber, I'm maneuvering the nucleus fragment into the anterior chamber. Then subsequently, I know that the anterior vitreous face is not broken, and I inject dispersive viscoelastic, because initially the patient was to receive a single piece intraocular lens. It was a 2.4 millimeter incision. I enlarge it to 2.8 millimeters, and behind the large nucleus fragment, I introduce a 3-piece lens and place it in the sulcus. Once you have this in place, then the propensity for the large nuclear fragment to fall back is significantly arrested, and with adequate amount of viscoelastic, I go ahead and do an anterior chamber phacoemulsification. Subsequently, go behind the lens, do an adequate anterior vitrectomy. Once again, use triamcinolone acetate to make sure that the anterior vitrectomy is quite adequate. So it's extremely important nowadays, whenever you even suspect that there is a vitreous loss, that you make sure with using this diluted triamcinolone acetate to ensure that the vitrectomy that you have done is quite adequate. And this is a vitreous wick. Here you will just keep concentrating on this particular aspect at 12 o'clock. Almost the entire surgery is going quite routinely, but once the nucleus fragment is completely evacuated, what I find is there is a slight distortion of the pupil at 12 o'clock. This immediately tells me something is wrong, because I had not really chafed the iris during my surgery. But as I was suspecting a vitreous disturbance, basically what has happened is essentially a capsular dialysis, and through that the vitreous has come out, though the posterior capsule itself is quite intact. So essentially the patient was to receive a single piece lens. So I go ahead and inject it. You can see already the vitreous popping out here. And then I inject a endocapsular ring in place. This was not, maybe it's the trauma of the surgery, because it was not a pre-existent problem. So I do not, it's not a progressive zonulopathy that we have, but I just want to give enough circumferential support. So go ahead and do an inject an endocapsular ring. Then subsequently in the subincisional area, do an adequate anterior vitrectomy. You can see the large blob of vitreous over there stained with the triamcinolone acetate. Then do an adequate anterior vitrectomy so that post-operatively, the chance of any retinal issues are taken care of. There's no inflammation, and you have the lens well settled in the bag and a good outcome. And you can have problems. This was a gynecologist friend of mine. One eye already operated with a premium intraocular lens a week back. Fairly routine surgery, fairly dense cataract. And you can see that the first time I suspected something wrong was when I found that there was something floating in the anterior vitreous. And then you can see a small, at this 6 o'clock position, there is a small discontinuity, and this is the area of the PCR, but adequate amount of posterior capsular support was available, and since the lady had already received a trifocal lens in the other eye, a continuous range of vision lens in the other eye, I go ahead and decide, and here I'm enlarging the incision so that I do not do a wound-assisted implantation, and I'm essentially directing the lens in the area where there's adequate capsular support. And in spite of this fairly large area of capsular defect, I'm able to implant a premium intraocular lens within the bag and get optimal results. So friends, the point I want to drive home is that posterior capsular rent is obviously a complication all of us do not want to avoid at any cost. But just in case you have it, you are always able to manage it. I just did not show anything happening in the posterior segment, because if there is a intraocular lens drop, if there's a significant lens material dropping in the vitreous cavity, then I think it goes beyond the realms of our capabilities, and it has a posterior segment surgeon help has to be enlisted. Thank you so much for your kind attention.
Thank you very much, Dr. Ram. Excellent presentation. I think all of us encounter such cases. Because we are running short of time, I think we'll just go on to the next speaker. That's the last but not the least, young upcoming surgeon from Center for Sight, Dr. Raghav Malik. He'll be talking about the third-hand pars plana instrumentation for the cataract surgeon.
Thank you,
So
Mahipal.
these are difficult situations wherein we are using the posterior approach to help you for the cataract surgery. Thank you.
Thank you, sir, for this opportunity. So I'll quickly jump into my talk for paucity of time. So basically, what I'm going to discuss is how a cataract surgeon can use the pars plana as a third hand and help in some complex cases. So I'll just start with a quick introductory video.
23-gauge micro-incision trocar cannula system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of 3 23-gauge trocar cannulas, an infusion pipe, and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar, threaded over which is a round-bodied cannula. Phaco, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
So now we'll see some cases how we can use this. So now let's quickly see a case where we all know whenever we encounter a phacomorphic glaucoma or a case of an intermittent white cataract, we know how difficult it is to make a rhexis because the high intralenticular pressure. If we do start a rhexis, we can either do a very small rhexis, or if we try and go into the mid-periphery, it can easily go into an Argentinian flag sign. This is a case where when we try this, you can see how quickly the rhexis runs off, and once you have an Argentinian flag sign, it is very easy for the nucleus to actually just drop into the vitreous cavity. Also, there's a high chance of having choroidals, and this is something which no ophthalmologist wants to see. So, to avoid such situations, we can use a pars plana cutter and a trocar cannula. So this is a case of a lady who came to us with a decrease in vision and a high and pain around the periocular area. So this was a phacomorphic glaucoma, and this is how we managed the case. So we did make a port 4 mm from the limbus, and once we go in, so the eye was rock hard. Even after giving a 300 ml of mannitol infusion, the eye was still rock hard, and we were not able to enter inside the eye. So you can see how we can do doing a small vitrectomy from the port so that the pressure from within the vitreous cavity is decreased. Once the pressure is decreased and we can remove some vitreous, you can see now easily we can enter into the anterior chamber, and once we enter, we start attempting a rhexis. Even now it is not very easy because there is still high intraocular pressure, and once you start a rhexis, we can always keep alternating between doing a rhexis and removing vitreous as required. So very slowly with dispersive viscoelastic, a rhexis is made. We try and not go too much into the periphery, and once a rhexis is made, we're able to complete and we go into the phacoemulsification. So phacoemulsification is relatively easy once the rhexis is done. And once we remove all the quadrants, you can see at this stage the iris is still coming up from the main port, showing that the intraocular pressure is high. You can see the eye is still again rock hard. Again, we come to the port and we remove vitreous. And once the eye is a little soft, we go in and do IA and implant the IOL. We do some vitrectomy from the main port and then implant an IOL and put a suture. One more case. This is a very interesting case. This was basically a patient sent to us. This patient had a trauma with a sharp instrument and actually had a white cataract, and the patient also had signs of retinal detachment. So now what we are doing is we are basically making a port and going from behind the lens so that we can actually cut the base of the vitreous. If we don't cut the base of the vitreous will keep coming as a wick. That's why we go in, make a port, and then cut the vitreous from the base. Once vitrectomy is done from the retrolenticular area, that's when we can go in and complete the cataract surgery and put in a 3-piece IOL. So that's how we want to go in, and if you can see, we want to remove the vitreous from the retrolenticular area. Once that is done, we can now go in and implant an IOL. This is one more case of a patient who came to us with a post-traumatic subluxation of the lens. We do go in attempt of flax. You can see that there is some vitreous in the anterior chamber, and very beautifully we can actually just center the rhexis as desired, and the femtolaser actually does pass through the vitreous. So it's very easy to make a rhexis and do some nucleotomy. So this is how we're going to center the rhexis. And once the rhexis is centered and as desired, we go into the rhexis and the nuclear fragmentation. This again, we make a port and we want to remove any vitreous that is coming through the subluxation. We know even while doing the femtolaser, we could see there's vitreous, so we know there is vitreous that's going to come out. Once we put Tramsolone, we can see that vitreous is now being egressed. Now, because we've done a femtolaser, we do get a free-floating capsular rhexis. And once the rhexis is out, we try and put an ECR before we do any nuclear fragmentation so that the nucleus is actually stabilized. And once the bag is stabilized, we go into a phacoemulsification. Quite easily, we can actually dismember the nucleus and remove the nucleus pieces. And once that is completed, we go in and do the IA. The IA will be a bit difficult because we have the ECR in place, but that's something that we have to deal with. Once that is done, we put in a 3-piece IOL in the bag. And in case we ever find that the lenticular pressure is increasing, intraocular pressure is increasing, we can always remove the plug and do vitrectomy. Now we go behind the IOL and do vitrectomy so that we again cut the vitreous from the base, and so that no more vitreous is coming into the anterior chamber. Once that is done, this is how the post-op looks. Patient was 6'9" on day 1. So this is again a case that was a blast injury from Afghanistan that was referred to us. So the patient actually had a very typical blast injury look, and you can see how this was a post-keratoplasty case. The multiple opacities in the cornea with no visualization, and there was a cataract. So we do use a chandelier system. Basically, it's a system of light that goes into the vitreous chamber, and the retroillumination gives us a very good glow. So this is how the patient looks under microscope light, and once we switch on the chandeliers, we can actually bypass the corneal opacity. So once you put in the trypan blue, and so this is how it looks, and now with the chandelier's retroillumination, we can actually go and do a rhexis, and the visualization is actually very good. And similarly, it also gives us very good depth perception. We can do a nucleotomy and fragmentation of the nuclei. Also, doing the irrigation aspiration is not a very difficult task. This is how the cornea is. We put in a lens under chandelier retroillumination. We put a lens inside the bag. And that's how we can manage such a complicated case with a Chandler's elimination. The patient went back very well. He was, of course, 18/6/24, but case was managed very well. Thank you.
Thank you very much, Dr. Raghav. I think he has shown the use of the pars plana approach to actually help you in cataract surgery. I think since we have a tea break, we can have 5 minutes discussion. Any questions to any of the panelists, or any panelist who wants to make any comments? Yeah. Go ahead.
Dr. Mahipal,
Yes.
in the case you have shown the small pupil,
Yes.
You first take up on surgery table and do the pupil expander, then you take on to the...
Yes, you will have to do
Yes.
that. You can wash the viscoelastic and put a suture. If you don't want to wash the viscoelastic, you have to increase the energy levels.
Oh, do you have any problems in docking after doing the entry?
Liquid optic interface, the only thing is you have to do the aseptic precautions to do that.
Then what was the indication for
You
flats?
can't use iris hooks because there are going to be 4 this thing. There you can have a problem in docking, but with a Malugin ring or with a this BX expander, that shouldn't be a problem.
So what was the indication for flax? You could have gone for routine phaco emulsification.
Oh, I think it was a hard cataract and you want to do that. It's also to show that some people say that you can't do flax in small pupils. If you have conditions of pseudo exfoliation, small pupil, you have hard cataract, is just to show that this is the way you can tackle that.
But otherwise if it was a routine cataract, instead of shifting the patient 3 sittings, you have to first cataract table, then you have to go to the flax machine, then on to the cataract.
Yeah, your point is right, but many times the flax machine is in the OT. So you really don't need to shift, you just need to shift the patient from one bed to the other bed.
Shift the patient 3 times.
No, it's only once. Because you just shift from flax to the normal OT bed, which is just next to it.
No, first you have put the pupil expander.
Doesn't matter, that's precious to the patient, the eye is precious, so you did basically, yes. Yes, ma'am.
The question is with Dr. Shreyas. Sometimes we have patients who are having very good dial on the cornea, clear cornea. So what is the preferred site to make main incision for phaco? Whether it should be posterior limbal, anterior limbal, or clear cornea?
Preferably a limbal incision. I mean, whether it's the idea is that we don't want to traverse the graftose junction. You want the incision to end before the graftose junction starts.
Okay.
And also making a slightly, as much as possible, a biplanar or triplanar incision to ensure that you have as little manipulation, iris prolapse from the wound.
Okay,
Thank you. One last question.
Yes.
Yeah, one last question.
Sir, I have a question to Dr. Gaurav. He's not here. In case of traumatic injuries to the iris, once we are putting in artificial implant into the eye,
Yes.
what is the risk of glaucoma in the long run in such eyes?
Anybody wants to take that?
Let me answer. Huh? I think it's a very good question. I think we were discussing also, these implants has to be in the bag. If they are perfectly in the bag, it's quite safe. If they are not in the bag, then you can have, inflammation, glaucoma, and corneal decompensation, which is very common. And the segments he showed, if you put only segment, they can easily be put in the bag, and you have less chances. But if you are putting the entire intraocular lens, which is larger size with peripheral pigmentation, and if there's a release of these pigments, then you have a very high chances of glaucoma inflammation happening. So whenever you're going for these implants, make sure you have a very authentic implants.
See, that's the problem that I was going to say. Ever since they came into medical devices, we are not able to take. I have no financial interest, but Morcher was really one where you did not have the pigment leaching out. You have the Indian people making it, and the pigment tends to leach out, and that causes inflammation and secondary glaucoma. I've lost one child's eye where I put an androtic segment with secondary glaucoma coming in. The patient didn't realize. So you have to be very clear, and I have serial pictures of the pigment going off and it not remaining as dark as it is. So Morcher was really fantastic, but they've stopped selling it because it's a medical device and it's not registered. So what Dr. Tityal is saying is absolutely correct, that you need to be careful that they don't cause any inflammation and put them in the bag.
I have a question for Dr. Chang.
Yeah.
Dr. Chang, I mean, I have seen your very interesting concept of three-piece lens with the haptics placed in the sulcus and the optic capture. How exactly does it improve zonular support in the sense that the zonules continue to be weak? You have not done anything to the zonules. How is it that it becomes more stable?
It's a really good question. I think that what puts the most stress on the zonules is the inertial displacement when the eye makes movements. And so when you have the haptics contacting the ciliary body, my theory is it's almost like you have scleral fixation. And that's really what braces the lens. And the bag just keeps everything from falling back, so you don't need the suture. So you're really not relying on those deficient zonules now. Because as you could see in that case when I jiggle the eye, just imagine how many times with saccadic movements you're shaking a tree and eventually the fruit falls off. So I think that's the theory at least.
Thank you very much. I think.
But David, I would really, no, just 1 minute. Why not to put lens in the sulcus itself rather than getting a capture into the bag which is not stable? Yeah. Because this bag is going to fibrose subsequently and that will create the problem. So my take will be I'll put the lens purely in a sulcus, leave the loose bag there. If you have jonular dialysis, it's a difficult thing. But if you just have a loose bag with the intact jonules, then the capture might work in those cases.
Yeah, I think that makes sense. Sometimes you can't capture the optic because everything goes back on you. The advantage, though, is if you capture the optic, the rexus cannot contract. Mm-hmm. And then you don't have the ability for it to rotate, which in the case of a zonular dialysis might be an issue.
Thank you very much. I think thank you for being here for the course. And maybe just, Kumar, one picture and then Namrata is already there. Thanks.
So we are going to begin the plenary session in another 5 minutes. And this is going to be the APO plenary session for the really coveted awards. And you are going to have plenary talks. So during this session, all the other halls are closed, and this is the only hall which is running. So I would request everybody to stay back for the plenary talks.